Good morning, everyone. Assalamu alaikum. In order to continue the lectures about the basics, so one of the basics is to understand the hemodynamics of the patients and to understand the numbers that we usually add in our reports and to translate this into a diagnosis later on. So we need to understand the calculations of QPQS. There are many methods, of course, that are available to measure the QS chest X-ray, but of course chest X-ray is not sensitive. However, there have been some research in the literature using the size of the pulmonary artery in order to measure the QPQS, but of course it's not specific and not sensitive. Echoes and catheters are so far they could measure the QPQS, but there is a lot of assumptions and operator dependent in the echo as well as in the cath. Where was the measurements of the oxygen in the proximal or in the distal pulmonary arteries? But I'm going to discuss how to measure it in MRI today, because so far CMRI is the gold standard non-invasive method measuring the QPQS without using any contrast to calculate those hemodynamics. In a normal subject, pulmonary flow has to be equal to the systemic flow. So if the net flow of blood going in the pulmonary artery is 1 milliliters, then 1 milliliter is going in the aorta to the systemic circulation. So this is a kind of a fact or an important fact, and based on this fact we could understand the numbers that we add on or we add to our reports regarding stroke volumes, forward flow and backward flow. As you all may know from the previous basics lectures, we knew how to measure the stroke volume, so we could measure it either using the cine, or we could use it, or we could measure it using the phase contrast sequences. So we could use the ventricular cine, for example, to calculate the stroke volume from the right ventricle and the stroke volume from the left ventricle. In a normal subject, the stroke volume right ventricle has to be equal to the left ventricle. Otherwise, either that the contouring is not good, or that there is a shunt, or there is a regurgitation somewhere. But in a normal subject, again, the stroke volume right ventricle has to be equal to the left ventricle. We do not prefer to measure the QPQS from the stroke volumes from the ventricular cines, because they are, I will go back again, as you may see, they are being calculated from multiple slices. Partial volume artifacts might lead to over or underestimation. Temporal resolution artifacts also may lead to overestimation or underestimation, in addition to if there is an irregular heart rate or motion artifacts. Blurring of the endocontour would lead to over or underestimation. Those are the limitations of calculating the QPQS from the cine, but if it's the only available sequence you have, then you are allowed to measure the stroke volume right ventricle has to be equal to the left ventricle. If not, the only possibilities are that the contouring is wrong, there is a shunt, or there is a regurgitation, and then it might be needed further evaluation. Phase contrast, as we discussed it in the previous lectures, so we could measure the aorta and the pulmonary flow using the phase contrast sequences. So we could calculate the forward flow and backward flow from those sequences, the phase contrast. There are some scenarios where it is simple to measure the QPQS, for example, VSDs, ASDs, or PDAs. So it's simple to measure the QPQS using the net flow in the pulmonary artery and the net flow in the aorta as representation of the QPQS, where the anatomy or where the shunt is at one level, possibly intracardiac, which make it very simple to measure the QPQS using the pulmonary flow, net flow, and the aorta net flow. This is a kind of a reminder. This is the planning two orthogonal views in order to obtain the aorta through plane, and the same perpendicular to the pulmonary artery in two orthogonal views in order to obtain a correct planning of the pulmonary flow, and then we would be able to, of course, to measure the forward flow and the backward flow in each vessel. And if we could calculate the net flow, then we would be able to measure the QPQS. The same we could do for the LPA and RPA. Here's an example in those cases. As you may see on the table, we have the net flow and there is no backward flow. So the equation here is very simple. The QPQS would be from the net flow calculated as 100 divided by 50. This would give you how much is the shunt in this case. And those are the scenarios where we could easily use this simple equation in order to measure the QPQS in those cases and scenarios. Another case where in a small patient who is post repair, just to emphasize the importance of calculating the QPQS from the net flow, not from the forward flow. So this is post-TOF. So if we calculated the QPQS using the forward flow, as you may see here, the regurgitation amount would be included in the equation, and this would lead to overestimating, or may show by mistake that there is a shunt, but there is no shunt. As you see in the net flow, calculating the net flow, the QPQS was fine and there was no shunt. This is an example of an ASD, so we could calculate it from the net flow. This would represent a QPQS from 2 to 1. But there are some other complex cases where the measurements has to be from elsewhere. Maybe some of you are aware with this image from the internet, where we could use the same planning perpendicular to the vessel of interest elsewhere in order to understand how to measure the QPQS in some difficult scenarios. For example, patients who had a glen where the superior vena cava is connected to the pulmonary arteries, whether on the right side or the left side if there is a left superior vena cava, which means that the lungs are getting blood through the superior vena cava, and the inferior vena cava is direct to the right atrium, which goes to the systemic circulation. So the source of blood to the lung here, in this case, the glen case, is the superior vena cava. So you could measure the pulmonary flow either by measuring the glen flow, which is here the superior vena cava, or you could measure the RPA and LPA, which would represent the blood going to the lung, but not the blood coming back in the pulmonary veins. And so this would represent the QP if we measure the superior vena cava or RPA and LPA. Blood coming back from the lung would represent the QP or the pulmonary flow if we are sure that there is no collaterals. But if there are collaterals, then we could measure the amount of collaterals by subtracting the total blood coming in the pulmonary veins minus the blood that went in the RPA and LPA. This subtraction should be 0 in a normal subject. But if there is an abnormal pathway like the collaterals, then total sum of pulmonary veins minus total blood RPA and LPA would give you the amount of the shunt. TCPC on the other side is when the superior vena cava and the inferior vena cava are connected to the pulmonary arteries, which means that pulmonary flow, or the QP, could be measured as the total sum of superior vena cava and inferior vena cava, or the total sum of the RPA and LPA, but please, or kindly, that's an important point, that we need to measure the RPA after the connection of the superior vena cava and the inferior vena cava. QS, or the systemic circulation, would be, of course, the blood that goes in the ascending thoracic aorta. Again, we could calculate the amount of any shunts or collaterals, subtracting the blood coming back in the pulmonary veins minus the blood flowing through the superior vena cava and inferior vena cava. Or, because sometimes, in many cases, it is very difficult to plan the flow in the pulmonary veins. So we could use another equation in order to calculate any collateral flows. As a matter of fact, it should be that the total amount that goes in the systemic circulation in the aorta minus the blood coming back superior vena cava, inferior vena cava should be zero, because any blood went to the systemic circulation should be come back in superior vena cava, inferior vena cava as deoxygenated blood. But if there is a difference, then this would allow you to measure the amount of the collateral circulation. An important fact that if we measure the blood in the descending thoracic aorta at the diaphragm level, and we measure the IVC after collecting the hepatic veins, they should be the same, because at the diaphragm level this means the blood went to the lower half of the body, and IVC after collecting the hepatic veins means the total blood coming back from the lower half of the body, and they should be equal. If there is a difference, so if there is more blood in the IVC than the descending thoracic aorta, this means that the IVC is receiving an abnormal pathway of blood, which sometimes happens in Fontaine and Glen, that there is a veno-venous collaterals coming from the superior vena cava, for example, to the IVC. So you could measure the amount of veno-venous collaterals if you subtract IVC minus aorta at the diaphragm level. Important is to measure the IVC after collecting the hepatic veins. Similarly, we could do if there is aortic collaterals coming from the descending thoracic aorta. So we could subtract the aorta proximal after the origin of the subclavian artery minus the aorta at the diaphragm. They should be equal, but if there is a difference, this would represent the amount of the collateral flow. And thank you.